mission to realize better health and happiness for people by being an integral member of the society, sharing common values and proposing new values through its business activities. Olympus, as a global company, is aligned by a strong shared purpose, which is making people's lives healthier, safer, and more fulfilling. The purpose statement of Olympus is driven by 5 core values: integrity, empathy, long-term view, agility, and unity. Companies that are guided by a strong set of values serve their customers better. Olympus caters to mainly 3 fields, namely medical, industrial, and imaging. Olympus roots into healthcare, innovation, and service to humanity that dates back nearly a century. In 1920, Olympus launched Japan's first microscope, Asahi, which was the only model made of gunmetal. In 1950, Olympus made its first flexible gastro camera, which came equipped with a photographic lens at the top of a flexible tube. The year 1985 saw the launch of Evis endoscopic video system. In 2002, EST devices were developed with Olympus equipment, and in 2004, Olympus's E-bus became the new standard for lymph node staging. In 2006, saw Olympus develop a narrow band imaging technology to enhance observation of mucosal tissues. NBI is an optical imaging technology that enhances the visibility of vessels and other tissues on the mucosal surface. The year 2012 introduced high-definition image system with brighter NBI and dual focus for precise diagnosis. 2013 saw the release of the Olympus 3D imaging system that creates a compelling 3D experience that is built upon many Olympus innovations and advancements. The Olympus HD 3D imaging solution provides improved speed, accuracy, and precision for surgical tasks. The year 2015 saw the introduction of the most innovative surgical system ever produced, the 4K surgical endoscope that gives 4 times more information than the conventional imaging system. In an endeavor to provide the best of medical equipment, Olympus Medical struck a series of partnerships and series of businesses. In 1979, Winter and Elbe became a subsidiary, and so did KeyMed Limited in 1987. While in 2010, Spiration Inc. also joined as a subsidiary. In 2011, Olympus acquired the ownership of US company Spirus Medical. Olympus Medical Systems India is a wholly owned subsidiary of Olympus Corporation Asia Pacific Limited and caters to medical and industrial domain. By 2017, we had established 9 major branch offices across the main metro cities of India, with its regional head office at Gurugram, and it is now expanding to all towns with its minor branches. The team at Olympus Medical has a mission to become the most respected, reliable, and chosen brand in the healthcare domain, with a highly trained and committed workforce. Olympus Medical Systems India has a wide portfolio of products that are equipped with the most innovative and clinically proven superior technology. Olympus Medical deals primarily in 6 medical technology categories: gastroenterology, general surgery, urology, gynecology, respiratory, and ENT. It contributes to the medical society with state-of-the-art products in categories that include video endoscopy, endoscopic ultrasounds, bronchoscopy, endotherapy devices in gastrointestinal and respiratory reach. The surgical division includes Ultra HD 3D 4K imaging systems and energy products for proper diagnosis in the fields of laparoscopy, general surgery, gynecology, and urology. Olympus India has been working with various educational bodies and teaching institutes to execute and propagate on how to use new technologies effectively and safely. We have participated in over 200 medical conferences and workshops in India. Olympus has an in-house ability to conduct academic training workshops, which are useful for educational purposes. Special training programs for nurses and technicians regarding the equipment safety and its efficacy are conducted and supported by Olympus India regularly. Olympus India welcomes various hospital managements and doctors for workshops and tours to showcase the repair processes, the complexities of repair, and skill set and expertise of our repair engineers in order to give them a peek of the Olympus service experience. Olympus Medical Service and Repair Center at Gurugram is one of the highly advanced repair facilities. Apart from this, we have a widespread network of 9 branch offices along with major and minor repair facilities across India. Our service and repair commitment consists of global standard of inspection and safety check, certified engineers and repair of all major products sold by Olympus India. We have a strategically knitted network of branches all over India to bring services and latest technology to different regions of the nation. Our foremost endeavor is to bring medical innovation and complete customer satisfaction. We are committed towards bringing new technological innovation, educational awareness, and comprehensive support and satisfaction to our customers. Our team of highly experienced and motivated professionals at Olympus Medical are proud to have contributed towards medical and healthcare facilities in India and the world.
Yeah, thank you very much. We'd like to pass to Dr. Lau. Yeah.
Thank you so much. At the outset, warm greeting from to all the India lab colorectal. This process followed by the last 2 or 3 decades, we have seen exponential growth in minimally invasive surgery. Of all the specialties or the subspecialties PI, colorectal surgery have overtaken. And because of the availability of the technology, the energy sources that are ever changing through the last 2 or 3 decades, there seems to be rapid improvements in the techniques because of these technological incorporation into these procedures. And a lot of publications and literature have come to show that colorectal surgery is becoming the gold standard for management of both benign and malignant colorectal disease. So in an endeavor to propagate this concept of minimally invasive laparoscopic surgery in colorectal diseases, we've partnered with Olympus to do this live webinar and workshop for people who are getting trained or are getting exposed to laparoscopic surgery in an aim to make this more popular. And this is basically done because of some survey that was conducted across the country and from all the registrants who have registered for this webinar to see what is important for them and why are they interested in logging into this webinar. So the main reason, if I can just show the slide, we've got some survey that was done, very well conducted by Olympus. Majority of are in have experienced surgery the last no more than 15 years. But surprisingly, comes to laparoscopic, majority of them still like to know the nuts and bolts of laparoscopy. Right? laparoscopic surgery. Hope you can understand. People doing only both open and laparoscopy very minimal. Now 33% of the people still doing open procedures. A fair number of people never ventured into laparoscopy. Now we to avoid these. So doing open procedure because of the advantages. Now also aside from this, want to attend this surprisingly challenges face them high, basically because a lot of them do not have training opportunities. AETF and also APLS. Thank you so much, Professor Kim, for accepting this invitation. Uh, he is basically the Professor of General Surgery Department and also the Head of Colorectal Division at the Korea University, and also the Director of Planning and Management Department, Korea University Hospital. He has extensive experience in laparoscopic and robotic colorectal surgery, and also seems to have a lot of experience in recurrent rectal cancer and pelvic extension procedures. It is because of his vast experience in this lap colorectal surgery, we've requested Professor Kim to share his experiences and also to share the nuts and bolts of laparoscopic TME. Thank you so much, Professor Kim, for accepting this invitation. I'm sure the participants would be immensely benefited by your talk. The screen space and the air space is all yours. Welcome, Mr. Professor Kim.
Thank you, Professor Lau. It's very good to see you, and thank you very much for inviting me this great webinar. It's very happy to see you despite this pandemic situation. I hope you Indians are safe and stay strong. So I will share my the screen. Okay, can you see this? Okay. So today I'd like to talk about the rectal cancer surgery, especially laparoscopic surgery, not just picking up the snacks in the bottom. You can see the such a frequency of the snacks in. I think it's very similar with the rectal cancer surgery. Why we think it is difficult to doing in a laparoscopic surgery. So it's just of data, the oncologic outcomes and the risk factors recurrence after the tumor specific or the TME after rectal cancer is a Korean report, but the distal resection margin and the circumferential resection margins are surgical quality related risk factors. We all of us know this. So why the TME and surgery distal and circumferential margin is important. We think about that. Is that this yellow side is a mesorectum. So we should dissect between the gold and the yellow lines is a proparectal fascia. This is a presacral fascia. It's a prehypogastric fascias. So when we go into the specimen side, if there is no tumors or the other thing, it is no problem. But let's think about that. Lymph node or tumor is in that side, then might be we will break the proparectal fascia. There might be a chance of the recurrence. Then how about we go into the deeper facial line? This red line means the present the hypogastric nerves or vessels or something. It can be cut. It may affect the quality of life of the patient. So we should keep the proper the dissection lines. So the most important thing is the creation of a proper surgical plane. The following orders. We should identify the landmark clearly and dissect the weak area first. Even the even the fatty and obese patients, they may have the weak area. So and they connect the two areas, the already dissected. We should all the areas. The last thing is the proper protection is very important. It should not damaging the mesorectal fascia. So let's think about the landmark. Landmark first, the mostly the easy to find landmark is the inferior mesenteric vein, and the when you grab just the side of the mesorectum or sigmoid colon, we can see the curves and fossas between the iliac vessels, or even the patient, the obese patient, we can create the landmarks. So another thing is after making the landmarks, we should dissect the weak area. Weak area, I means that we can infiltrate the airs with the monopolar cauterization. So it is the weak area make the grooves or fossas there. So we pick up the inferior mesenteric vein. We can see the grooves between the aorta and the inferior mesenteric vein. There is a grooves, and there is another grooves here. So this is the most weakest area. So the monopolar, we can use a monopolar cauterization to infiltrate the airs through the weak area. We can see the thin facial layers there. So this red line is the weak area first. There are two weak areas just below the inferior mesenteric vein, and this group is made by a traction of the inferior mesenteric artery. So after that, we can connect these two planes. Then we can see the inferior mesenteric artery. So dissection along the mesorectal plane and the TME planes are not two separate dissection, but rather a continuous dissection along a continuous embryological mesodermal plane. So I'd like to say the TME dissection begins at the level of the left colony mobilization. It means that many surgeons regard is a there is a two steps. The first step is the left colony mobilization, and after then we proceed to TME. And so some young surgeons think that the left colony mobilization and TME is a totally different uh, the different procedures. But I think I'd like to emphasize that the left colony the TME is an extension of left colony mobilization. So we should keep the embryological plane from the start. So I'd like to ask you guys, which plane do you prefer? This yellow is a major rectum, this round is the rectums here. The green line is the proforectal fascia. So this is a sacral side, is a facial, the facial plane, presacral fascia, or the pelvic bone, whatever. I think during the dissection, we meet the gray areas. The Professor Hill says this fibrous tissue, connective tissue plane is called as angel's hair. You can imagine that there is the many hair-like structures there is a fibrous structure. So the TME plane is a holy plane. So the Professor Hill they usually call it the angel's hair. So number one, two, three, there is we can cut into the TME plane with three the anywhere. So it's a left side pelvic wall. There may be we can close to the mesorectum and just the middle of the angel's hair. And the another thing is we can follow the lowermost portion of the facial line. But Professor Hill said we can see two sides during the TME. One side is white and the other side is yellow. But he said follow the yellow line. Let's back to the presentation. So he recommends follow the number one line close to the mesorectum. Okay, so let's imagine the posterior posterior part of the rectum. It is very easy to dissect at the first stage. It may be all the surgeons will agree to that because this is the imaginary dissection plane of the posterior part of the rectum. This is the proximal part is the cephalad direction. This is the caudal part of the direction. Posterior part is a very easy to make a plane, and the end of the rectum there is a somewhat wider comparing to the middle rectum. I will show you the why. This is the image, the imaginary plane of the posterior, the rectum. So this is the cephalad direction. This is the caudal direction. There is a wing because the rectum is sit down on the pelvic floor. The distal part is somewhat wide. Yeah. So when you dissect the posterior part, dissect the middle line first and spread it the lateral side. It is easy to do. The I already mentioned that weak area should be dissected first, and the weak area bridged with the loose connective tissues. The and the lateral side, there is an area of neurovascular bundles. That area, the area of a neurovascular bundle is somewhat thicker than the other area comparing to the posterior and distal part. So leave this area as the last step of dissection. Let's have a look. This is the post part, and follow the yellow side close to the mesorectum. Because we can dissect it with scissors or monopolar cauterization without energy devices. It's very sorry to say to the Olympus, but this area is very weak. So we can use the monopolar scissors. I like to use monopolar scissors because the original article says that the TME was done with scissors or something. This is the distal part. We always should to find the weakest area without large vessels and then dissect. The complete denudation of the mesorectal tissue is very important to make such a stapling. It's ultra low entry section after the connection of the proximal colon. We can see the dissection very close from the anus. Let's have a look this video clip. This video clip was created by Professor Hill. What is the most important thing shown in this video clip? I think the proper traction. Proper traction can be created by the surgeon and assistant surgeon, and it's not my the figure, but it is brought from the Japanese surgeons. It is a triangle tissue triangulation. It is very important in all kind of laparoscopic surgery. So during the rectal surgery, this kind of traction can be created by the assistant. It is a so-called matador technique. It is like the matador, the two fighter, the bullfighter of Spain. They are called as a matador. They hangs the caves. So it's like that kind of procedure. So assistant handles the rectum like this. Assistant right hand hold the left side of the mesorectum, and right side hold the left side hand hold the right side. Of course, it's the patient right side. Hold the patient right side of the mesorectum. It create the more it create the very nice view of the posterior part of the mesorectum. So I'd like to share my technique of techniques to make the proper the surgical field.
Hello, Professor Jim Kim.
Yeah.
Actually, like a voice is not coming.
Oh, really?
Yeah, yeah. So that,
Okay, I see.
yeah, just you try to that.
How about this?
So now, I think it's not yet to come. Yeah. So the if you touch upon to
Okay.
this point, yeah.
Okay. Yeah. Then I will explain this video clip. Actually, the video contains the voice, but I heard that it is not the played. So is the inferior mesenteric artery dissections. So I made this. Sorry. Yes. So I will show you this one. I place this gauze. It contains the steel wire. Steel wire used by orthopedic surgeons because I don't like to have some stiff traction. So give it to the left colony when you use it during the left colony mobilization. We can see the wide view of the dissections. Okay, such a wide view is very important during surgery. Sometimes it is very frustrating to make the surgical field. So just one hand is used for during this dissection. Okay. Such a traction make the operation very easy. Okay. If we have the wider view, we can dissect more easily. The another thing is the pillow is a very steep gauze. You can see the dissection plane somewhat easily and wide view. And surgeons will make the feel is very comfort. Another thing is the retraction using the rubber band. I place it the side of the mesorectum. And retract it through the abdominal wall. During the rectal dissection, I use this kind of tricks, and I can do the TME dissection without assistance of the another assistant surgeon's help. It's very simple to make and simple to use. Okay. This is another trick. Then after doing some part of the dissection, and retract the uterus first. And then I place the retracting gauze and sutured the both sides with a thread and lifting it up to the abdominal wall. With using these tricks, the assistant can use both hands, retract the mesorectum. Okay. I'd like to introduce another personalized instrument. This I tie the nylon tape between the bowel grasper and retract the distal part of the rectum more efficiently, I think. And it can also prevent the sliding out of the rectum without the damage of the tissue. Okay, I'd like to say that this cliche from the other people, it is told by Einstein. Imagination is more important than the knowledge. Knowledge is limited. Imagination encircles the world. So in conclusion, I'd like to say like the follow the standard. The standard is they already published and showed by expert surgeons. So and make your own standard, and finally try to exceed the standard. Thank you for listening. Okay, I finished.
Thank you, Dr. Kim, for an excellent overview of the different tricks and techniques which you have developed. I think I'm damn impressed with your using a rubber band to have another assistant. And I have a couple of questions, Dr. Kim. So how do
Yeah.
you highlighted the important points of a good traction, counter traction. That's very important. And
Yes.
remaining in the correct plane. If you are in the correct plane, I think the most important monopolar is a very good instrument. You don't require high-tech gadgets.
Yes,
Very
right.
good point. And I have difficulty in sometimes handling a bulky rectum where you don't have much space to work around. So are there any
Yes, right.
tricks for us to handle a bulky rectum where in a male pelvis particularly?
Yes, right. Yes, right. So botulectomy is also difficult to retract by assistant and of course by the surgeon. So in the kind of case these days, yesterday the patient I operated on was she was just 150 something height, but the weight was more than the around 100 kilograms. In that kind of case, I expected that she was in women they have the very a lot of subcutaneous tissues. I expect that there might be it might be okay in the mesenteric fat, but she also have a lot of fat tissues and bulky lectins in there. But in the case I used the I used the lifting technique showed in the previous videos like this. This one was this technique was so the valuable and it was very helpful. So with using these techniques, the assistant also can use assistant hands are very free. They can use they can give you other retractions during the TME dissection. Of course, the bulky rectum there is the difficult for the even to the expert surgeon, I think. So in that kind of case, you should keep in mind then not to injure the proper rectal fascias. But it is also difficult to everybody, I think.
Okay. Another, if a small lesion in the rectum, how do you assess the distal margin? Do you do an intraoperatively per rectal evaluation, or you do an Indian ink or some marking preoperatively to locate the level of the lesion so that you are sure when you during laparoscopy that your distal margin is well away from the tumor?
Yeah. In that kind of situations, I ask uh, the um, the tattoo preoperatively because the rectum is very short comparing to the other organs. So, but in that kind of in early cancers, so for the early cancers, I'd like to leave the distal rectum as much as I can. So I ask the clipping, or sometimes I do the intraoperative colonoscopic examination.
So, any word about TATME? What is your opinion on TATME versus the lap?
Oh, yeah, TATME so far, I think the it's a relatively new technique. So far um, the I don't feel I need it very eagerly. I don't do the TME at this moment because I usually deal the Asian patient. Well, actually I don't know the the efficacy of the TATME.
Yeah, I think we also feel the same.
Yeah.
Uh, Thank you, Kim, for an excellent talk and telling some tricks for the young surgeons and even the
Thank you
experienced
very much.
surgeons also.
Hello, sir. Hello, sir. We have receiving two queries from the participant. Yeah. So the one query is how the rubber band are sterilized. I think it's really India, the question. So that if you have any answer, how the rubber band are sterilized.
Excuse me, I cannot hear you. Sorry.
So can you hear me?
That is the
Yeah.
okay. Is that a question for me?
Yes. Yeah.
Oh yes. Please again.
Yes. Two questions we have received from the participant. Yeah.
Oh, okay, I see.
How the rubber band are sterilized? You are using like disposable, or also you are using as reusable?
I use the reusable the instruments for the for the dissectors or something, I usually use the reusable the instruments by the from the Olympus. You can see there.
Thank you. Yeah. So the participant question is a rubber band. Yeah, maybe in your presentation you showed some of the color rubber band. Yeah. So the you are
Yeah, rubber
right.
band.
Yes.
Oh yeah, of course it is sterilized. Of course, we use a sterilized one. Actually, the we should have some steps to using in during the surgery because it is actually it is not for medical use. These days, I use the medical rubber band the produced by 3M.
I see. Thank you very much. Yeah. Another
Thank you.
question. Yeah. Do you have any advice in finding the brain in patient who had chemorrhagiations?
Chemorrhagiations is also difficult. There are the tissues are very there are fibrosis and inflammation. Inflammation causes the some the fluid extraction from the tissues, but it is also difficult to do. But most of all, the case are done by a laparoscopic. Of course, it is difficult to everybody, I think. But the patient who have the indicated to do the chemoradiation therapy, of course, it should be done. Anyway, we should do the surgery. Anyway, yeah.
I see. Yeah. Thank you very much. Yeah, that's it from the participant. Thank you.
Thank you.
Thank you, Kim. Can we move on to the next talk, please? Yeah. So now the next speaker would be K. Uera. She is an assistant professor and chief of colorectal surgery, division of surgical oncology from Nagoya University School of Medicine. And her research and clinical interests are surgery for locally advanced and recurrent rectal cancer and extended pelvic surgery. Dr. K. Uhara, are you there?
Yeah, yeah.
Yeah, go ahead.
Oh, hi. Hello. Good evening.
Good evening. Good
So
evening.
nice to see you.
Yeah.
So I'm Uehara from Japan. So thank you for your kind invitation for such an excellent webinar and giving me the first opportunity to talk to Indian surgeons. So today I'm talking about so lateral lymph node dissection. So so Professor Kim, please close
Oh,
your
okay.
sharing. Okay, thank you. So I will share my video. So today, so I use so video presentation.
Hello, Dr. Uehara. Voice is
Oh,
the one.
okay.
Yeah, once you close to the presentations, then
All right.
yeah, I think when you share the screen, then also you have a choice to the share the voice also.
Share the voice. Sorry, sharing. Oh, okay, okay.
Yeah.
I know. Maybe it's okay. So nice to see you. Can you see me? From Japan. Can
Yes,
you
yes.
hear?
Now it's perfectly
Now.
coming. Thank you.
Thank you very much for your kind invitation. It's my great honor. So now I cannot join the real conference. I'm looking forward to seeing you in India next time. So today I'm talking about lateral lymph node dissection. I'm from Nagoya, the third biggest city located at the center of Japan. So I'm between Tokyo and Osaka and very near from Kyoto. early in April, we can see their beautiful cherry blossom as usual. So this is my poster building and all the nerve capsules. Lateral ring metastasis occur in 14% of the patient with T2 or deeper disease and 28% of the patient with stage 3 disease. Lateral lymph node metastasis occur more frequently than upward lymph node metastasis. So this is a schema of the pelvic sidewall. We have the concept of 3 partitions. So partition 1 consists of autonomic nerve system. So partition 2 consists of internal iliac vessel system, which includes the main trunk of the internal iliac vessels and several branches to the urinary bladder, prostate, and the neurovascular bundle. Partition 3 is the lateral partition. So this is the outside muscle, which includes the internal obturator muscles. We have to carefully expose and preserve this partition and dissect lymph nodes between the 3 partitions.
ಇದ್ರಾಗ ಹಾಕ್ರಿ ಇದನ್ನ
Video of standard lateral dissection with autonomic nerve preservation. The ureter is mobilized. So first we remove the lymph node in the proximal internal iliac area. So we mobilize the hypogastric nerve and then we expose the internal iliac artery and vein. So inner side of this area is the hypogastric nerve and the outside of the
बहुत
this
टाइम
area
unnecessary
is
waste हो रहा है ना अरे
iliac artery
ठीक है
and
कुछ नहीं
vein.
कर सकते
We remove this partition.
यार
The
पूरा
bottom
प्रोसीजर
of the
दिखा
area is the sacral surface. We expose the sacral surface here and remove the partition. Okay, and this is so first branch of the inferior vesical vessels. We remove it, and we preserve the pelvic plexus. Then we move to the obturator space lymph node dissection. So this is the basic hypogastric fascia. This is landmark of the inner side of the obturator space. And then we expose the external iliac vein. And distally we expose the bus. And this is a lymphatic chain to the inguinal lymph node. We divided it. This is the obturator nerve. And we expose the internal obturator muscles. The dissection is proceed down along the internal obturator muscles. So again, this is the inner side, the lymph node, so outer side of the basic hypogastric fascia is removed. And then we reach to the end pelvic fascia. Okay. We preserve the obturator nerve and we divide it the obturator vessels. So this is the vein. So we have several vein lines, so carefully divided it. Okay. And this is the proximal side. And this is the sacral nerve. And the bifurcation of the external and internal iliac vein. We preserve the obturator nerve and divided the obturator artery and the obturator vein. And this is the bottom of the obturator space. This lymph node is along the main trunk of the internal iliac artery. We removed it. So we completely remove the obturator lymph nodes. And so distal internal iliac lymph nodes after lymph node dissection. These are my favorite tools. I usually use monopolar electrode cautery. I prefer Olympus, flexible scope, and Thunderbeat and Ligasure. So both are useful for white surgery. This is the JCOG-012 trial. So this non-inferiority trial compares the TME plus lateral lymph node dissection to TME alone. The primary endpoint was relapse-free survival. However, this trial could not show the non-inferiority of TME alone compared to the TME plus lateral lymph node dissection. Relapse-free survival were almost same in both groups. The long-term outcome shows that lateral lymph node dissection is recommended for clinical stage 3, whereas could be omitted for clinical stage 2 disease. This is the latest Japanese guidelines. Lateral lymph node dissection is divided in the clinically positive and negative groups. For clinically positive cases, lateral lymph node dissection is strongly recommended. On the other hand, for clinically negative cases, the recommendation is weakened. Necessity of lateral lymph node dissection in patients with clinically positive lymph nodes has been gradually accepted in the world, including the Western countries. Our study offered an opinion that CRT with TME might not be sufficient in patients with enlarged lateral lymph nodes. This is multi-center pooled analysis from 12 centers worldwide, with over 1,400 patients operated over 5 years. The patient with enlarged lateral lymph node, the short axis 7 mm or longer, had a significantly higher risk of local recurrence and lateral local recurrence. After lateral lymph node dissection, 5-year lateral local recurrence and local recurrence rate was significantly lower in patients with enlarged lateral lymph nodes. So lateral lymph node dissection is required even after CRT in patients with enlarged lateral lymph nodes. So how is the significance of re-evaluation after CRT? So in the Korean study, showed the lateral lymph node size, so short axis longer than 5 mm, after CRT was the only independent and significant predictor of lateral lymph node metastasis. So they concluded the routine lateral lymph node dissection for all node enlargements detected on MRI before CRT may be considered as over-treatment. But similarly, our second study showed the persistent enlarged lateral lymph node short axis longer than 4 mm after CRT was a risk factor of lateral local recurrence. So good responder could omit lateral lymph node dissection even in patients with enlarged lateral lymph nodes before CRT. However, the cutoff size remains controversial. Then, you left the enlarged lateral lymph node as it. Oh. This is a case of a 48-year female. So she underwent the CRT followed by APR, combined the resection of the uterus and the ovary. This is a CT before initial surgery. So this is a lateral lymph node. So this is 1 year after CRT followed by APR at the previous hospital. The lymph node was increasing. So we could reject somehow, but a large lymph node should be removed at the initial surgery. So lateral lymph node dissection is the essential procedure for lateral surgery. Opinion. Current recommendation of lateral lymph node dissection is for patients with clinically positive lateral lymph node, a large lateral lymph node after CRT, so strongly recommended. Shrunk lateral lymph node after CRT is controversial. So in upfront surgery, it's essential. So for patients with clinically negative lateral lymph node after CRT, now upfront surgery in clinical stage 2, so it could be omitted. And in clinical stage 3, it's a good indication. So however, so is it rare? Isolated lateral lymph node metastases sometimes occur even in T1 tumor without mesorectal lymph node metastasis. So preoperative imaging diagnosis is quite important even in T1 to tumor. The most important but difficult is the removal of the lymph nodes at the bottom of the obturator space, so but far from the abdominal wall. So this is angiogram. When it is rotated, it's the same. The human anatomy is unchanged from any figure we see. And the surgery we should do is also unchanged. So in transabdominal approach, the most important point is the most distant and vertical access is required. But in the transanal approach, it was nearby the anus and parallel access is permitted. So I will show the video of the transanal lateral lymph node dissection. After APL, the right side of lymph node dissection was performed along the levator muscles. Then we cut the inferior pubic ligament and enter the obturator space. The dissection along the internal obturator muscle was proceeded up. We can see the obturator vessels here. At the inside of the obturator space, the pelvic plexus was identified and definitely preserved it. This is S4 nerve. S4 nerve is here. We preserve it. And then the vesical hypogastric fascia between the inferior vesical vessels and the obturator partition was confirmed as the landmark of the inside of the obturator space. So this is the vesical hypogastric nerve fascia is here. So nearby the obturator fossa, the obturator nerve was identified. This is the obturator vessels. So this is the obturator vessels. Okay. We encircle the obturator vessel. And behind the obturator vessels, we can see the obturator nerve here. We clipped the obturator vessels and divided them. And this is the obturator nerve. And this is the psoas muscle. And then this is the external iliac vein. Here we preserve the obturator nerve. And this is the external iliac vein. And this is a vas. So again, this is a S4 nerve and the inferior vesical vessel. So we divide it along the vesical hypogastric nerve fascia. This is so obvious fat tissue. This is inferior vesicle vessels. This is the alveolar canal, the bottom of the obstructor space, the more frequently metastatic area of the lateral space. We divided only the fat tissue of the obstructor space. So we can divide the fat tissue using the parallel axis. This is the vesical hypogastral fascia. Here is the bottom of the obstructor space. And this is inferior vesicle vessel. So this is a lymphatic chain to the inguinal lymph node. This is external iliac vein. Again, here is the bottom. And this is the obtrusive artery and divided it. So this is the main trunk. This is external iliac vein. It preserves the obtrusive nerve. Okay, we remove the obtrusive fat tissue. So this is after lymph node dissection. So this is from the abdominal side. So obtrusive fat tissue is clearly removed. So in lateral lymph node dissection, which approach is better, transanal or transabdominal? So I think a transabdominal approach is easier and more familiar for us. So why you do it? So I think the potential benefits of a transanal approach is in usual surgery, we don't need to open the pelvic sidewall peritoneum. So maybe it reduces the postoperative bowel obstruction and reoperation will become easy. So in fatty patients, so it can help the transabdominal approach in two-team method. And in patients with suspicious lateral lymph node, even after CLD, so at the bottom of the obstructor space, so pick up only targeted lymph nodes, so without systematic lateral lymph nodes will become possible. So this is my conclusion. And large lateral lymph nodes should be removed. So transanal lateral lymph node dissection is an easy way to access the deep lateral pelvis and might be promising for selected patients. Thank you for your attention. See you.
Thank you, Hera, for an excellent demonstration.
Thank you very much.
Excellent demonstration of the lateral lymph node dissection. And outside Japan, very few centers believe in lymph node dissection for lateral lymph node dissection in rectal cancers. So one of the reasons might be more complexity involved in it, and it did not translate into survival advantage. So that might be a reason why outside Japan, very few centers do lateral lymph node dissections. One question to you, Vera, if a preoperative, pre-radiotherapy lymph node after radiotherapy disappears completely, do you still advocate lateral lymph node dissections, or you want to follow up these patients?
I'm sorry?
after neoadjuvant therapy, if the lateral lymph node disappears completely, will you still advocate nodal lateral lymph node dissection in this group of patients?
So after proper treatment,
Yeah, after radiotherapy.
so it disappeared.
Yeah, complete disappearance.
So we don't do it.
Okay.
Only persistent swelling lymph node.
Okay.
So it's after neoadjuvant treatment. But so in Japan, so we usually do upfront surgery. So without so proper treatment. So for such cases, so we think so lateral dissection is essential.
Okay. Kim, what is your approach in lateral lymph node dissection? Do you believe in lateral lymph node dissection in your center? Do you do lateral lymph node dissection in your center?
So I'm sorry, I cannot hear your voice. I'm sorry.
I'm asking Dr. Kim whether he believes in lateral lymph node dissections in his center.
Also, I think like your mic seems like a not voice is not much.
Very so.
So that if we yeah. So if you can change to the mic, I think that is better. Yeah. Do you have like other mic?
Yes, some distance will happen.
Yeah.
Okay.
Yeah, Kim,
I
what
think
is your
they-
view on lateral lymphadenectomy?
Yes, I do the lateral lymphadenectomy for the rectal cancer patient who has I just do it. It's very obvious on the MRI, and so I think that these days I changed some my practice. If it is obvious pre-radiation, it's very obvious, but the even it decrease in size after the chemoradiation therapy. I do the lateral pelvic lymph node dissection, but in my experience, the positivity rate is very low, very low. Yeah, so
I agree to you.
yeah. In the other hand, we can say there is the over treatment, but I think that there is a possibility of the recurrence of regrowing or comeback of the cancer after some period of the finish of the treatment. I think so. These days, if we can see the small lymph nodes on the post-radiation MRI, I do the lateral pelvic lymph node dissections.
So I agree to so Professor Kim. So this the potential advantage of this approach is so only pick up the swelling lymph node. So pick up only the so located at the bottom. So systematic lymph node dissection is I think over treatment. So for such cases, this is a so good approach, I think.
Yes, right. It's very nice approach, and but I think that is somewhat difficult to. How many cases do you need the overcome the learning curves? Do you think?
Yeah. I think actually it's not easy to do it.
Yeah.
So, but so after APR or ISR or after TATME, so we have a channel. At the anus. So after that, so we can try. So if we cannot, so I can change the approach from the abdominal side. So so before that, so we should try. It's one of the training.
Yes, it looks very difficult.
It's so like a single port surgery.
So okay, I see.
It's a difficult, I think.
Thank you, Ara, for an excellent demonstration of the lateral lymph node dissection. So now we move on to the live sessions from the Asian Institute of Gastroenterology of India.
Hello, sir. Yeah. Hello. We have received some of the query from participants. So that can I ask the doctor?
Okay. Go ahead.
Yeah. Thank you very much. Yeah. So is the transanal NLD lymph node dissection better than laparoscopic approach technically? Yeah.
So technically it's a difficult, more difficult. I prefer the abdominal approach. But I show some potential benefit. So if we can, so for selected patient, it's sometimes it have advantage. It's one of the choice.
Yeah.
So we
Thank
have
you.
some weapon.
Yes, a lot of options, I think. Yeah, good.
And another questions for the lateral dissection, what is your access if you accidentally injured external iliac vein?
Oh, it actually I have only one case. So in the interface, it's my it's early experience. So for in such cases, I converted the open surgery and repaired it.
I see. Yeah. So I'm sorry, we have received many questions. Yeah. Like next question is, does your method for transanal approach change in any way if you need to do an extra levator excision?
Oh, it's a transanal approach. Extra repertoire excision, maybe so after wide excision of the anal skin, it's difficult to do a transanal laparoscopic surgery. So because we cannot use it's a but it's a maybe wide excision we cannot do maybe.
So last questions. Do you remove the various lymph node pockets individual specimen, or do you leave them with the main specimen?
It's after at that case. So after remove the main specimen, we do lateral lymph node dissection, and then remove the lymph node specimen. It's okay.
Yeah. Yeah. Thank you very much. That's it from the participant. Yeah. Thank you very much.
Thank you very much.
Thank you, Vera. We'll be moving now shortly for a live demonstration of the low anterior resection. My colleague, Dr. Sanjeev Patil, will be doing it, laparoscopic low anterior resection. And we have a case presentation with details about the case. Dr. Manikanta will be highlighting about the case details before we move on to the theater.
Good afternoon, everyone. This is a case of 47 years male patient. He is no comorbidities and no previous surgeries, with 6 months history of progressive constipation and bleeding PS since 1 month, with significant history of loss of weight and loss of appetite. And digital rectal examination that the growth is well above and that is not palpable. We have evaluated with colonoscopy that is showing the ulcer proliferative growth in the lower sigmoid and rectosigmoid. Biopsy showing the moderately differentiated adenocarcinoma. So we have evaluated the PET CT that is showing the there is no evidence of distant metastasis, and there is circumferential growth confined to the rectosigmoid and upper rectum with periregional lymph nodes. So we are planning for the laparoscopic low anterior resection this patient. Over to the Sanjeev Patil, sir.
Yeah, very good afternoon. So as you all know, this is a case of lower sigmoid tumor. So we are planning to do an anterior resection. Actually on imaging we were not very sure. We were thinking that a rectosigmoid is involved, but the lower sigmoid is involved here. So we are now planning to do a laparoscopic anterior resection here. Hold this. So first of all, we have done a diagnostic laparoscopy. There is no evidence of any metastasis anywhere. You can see the right ureter here. Come close. This is the right ureter. So we'll take down the IMA. Usually in the sigmoid malignancy, if it is a lower sigmoid malignancy, we prefer to take the inferior mesenteric artery as the nodal clearance is better. But the only precaution that we are supposed to take is not to leave any part of the sigmoid behind. That is, you have to go up to the peritoneal reflection and then transact at the rectosigmoid junction. So that is the precaution if you are sacrificing the inferior mesenteric artery. That's what we are planning to do here. So this is one of the latest instruments which has come into the market, which I am using now. This is a Olympus ultrasonic generator, which is 410. The previous one was 400. The amount of fogging is a little less here compared to the previous generator, and the speed of vessel sealing is also better. They say it is around 30 to 35% faster sealing compared to the previous generator, and it can seal vessels up to 7 millimeters securely. So we'll try to, though we usually apply a clip for the sake of safety, in this particular case I'll try to demonstrate whether inferior mesenteric artery can be taken down without a clip. So usually even in the case of low anterior resection, we ligate the inferior mesenteric artery lower down, that is low ligation, distal to the distal to the left colic origin. Come close. Sister gauze piece ready. This is the inferior mesenteric artery that you are seeing. Come close. Come close, come close. Now you can see the inferior mesenteric artery there. I am trying to create a groove between the vein and the artery. Lot of lymphatics structures will be between that. It is better to dissect and divide with the harmonic. Now the inferior mesenteric artery is seen well. That is the vein. Yes. Sister gauze piece. Gas out. Come back. Come back. Gas out chamber. Come in, come in, come in, come in.
wavelength. Gauss is the color. Gauss the curve. Come close. Come close. Maryland sister. 1 second. फोकस ऑटो नहीं है उसमें. दैट इज 4K ना. कम इन. Clip ready పెట్టుకోమ ఒకటి. Keep a clip ready. Thunderbeat. So I'll be taking the vein now. So the sealing efficacy of this particular instrument is supposed to be very good. So though we apply clips, we'll try to do it at the end of the transaction just to see whether the, see, you can see here, sister, clip, gauze piece, gauze the, so it is very well. Come close, come close, clip, Maryland, left hand Maryland, clip, that's better, regular metal clip, come close, come close, come close. I am applying a gauze piece, is enough. Metal clip for the sake of safety, but safely 7mm vessel can be transacted using this instrument, but specially sealing of the vessel is better with arteries than with veins because of the amount of collagen tissue that is present in the wall of the arteries. So always it is safe to clip the veins. This is the inferior mesenteric artery. We'll try to dissect it and again transact it with the Thunderbeat and see whether it is effective. Yes, I will make a length. Yeah. Show me the gauze. This appears to be a vessel which is more than 7mm, but still will try to so the other advantage here is it has bipolar with ultrasonic energy. What I am now trying to do is to coagulate the vessel using bipolar energy, and once it is completely coagulated, then we'll try to transact it and see. So I'll do it another time. You can see the sealed vessel here which is pulsating, come close, which is pulsating very well. Though applying a clip is always a safer option, so now we'll just apply a clip there for the sake of safety. Maryland's left hand. Hemolog. 10 hemolog. Gas off check. Come close, come close. Yeah. So as you saw here, it is a very effective energy source where you can even
transact artery like an inferior mesenteric artery which is of a diameter of more than 7 millimeters.
Yeah, what Sanjeev has done is actually this is for a demonstration purpose, but we wouldn't like anybody to be doing this actually this sort of heroic procedures actually. So but when you mobilize the we have a fairly long segment of this vessel that is dissected out. We should be able to do this, but it is more to demonstrate that these larger vessels can be very effectively sealed using this new generator that has come from Olympus. And as you can see that the instrument has become more compact now. The delivery is more effective now, and it is almost about 30 to 35% more efficient than the previous generator that is available. And the biggest advantage seems to be that it is able to take bigger vessels like what you've seen. Again, it is not that we are just going to leave these bigger vessels. We have to have secured these vessels very effectively. But it is the biggest advantages are suppose in areas where you're not able to get access to the clip or anything of that sort, and some of these smaller vessels can be clipped. The biggest advantage, again, as Sanjeev has told you, I think it seems to be creating less vapor than the previous generator. I think that is the biggest advantage. The image seems to be very clear right through the dissection. You can see hardly any, the number of exchanges of the camera seem to be quite less during this entire process. So I think with the improvement in this new generation Thunderbeat, I think procedures will definitely be faster. I think Sanjeev will accept with me that the instrument is also faster, more efficient. I think it seals the lymphatic because we are able to seal major vessels. I think lymphatic should not be a problem, so that the post-operative morbidity could be quite less in these patients. The other big advantage that we have is using this 4K laparoscopic systems actually. Again, the colors that we have on Olympus seem to be absolutely close to the real life scenarios. So we seem to be operating on images which really look like what we do in open surgery. That is the closest to what we have compared to any other system. We feel that the Olympus systems are absolutely give the very near natural colors. And the magnification is so phenomenal that the dissection is faster, getting into the planes is easier, and we are able to see these planes very clearly. The amount of bleed is less in these patients, and certainly the procedure is faster and the post-operative morbidity seems to be less. Sanjeev, now that you've secured this, you just keep dissecting the thing. Actually, we'll go, Manikanda, can you give the presentation of the next case, and then we'll go on to the other theater to show the right hemicolectomy. Then we'll come back again to this theater.
Yes, sir. Next case, that is a 48 years female with she has a diabetic hypertension, hypothyroid. She presented with 2 months history of abdominal pain, abdominal distension, and occasional vomitings with history of significant loss of weight and loss of appetite. So we have evaluated, and her hemoglobin is 10.6 and albumin was 4.3, and colonoscopy showing there is a large ulcerated growth in the ascending colon with the component of intersusception, and biopsy was suggestive of poorly differentiated adenocarcinoma. So we have evaluated with SPECT-CT that is showing the only there is no evidence of any distant metastasis. That lesion was only confined to the ascending colon. So we have planned for the laparoscopic right hemicolectomy. Over to Dr. Shreyas.
Good afternoon. So this is a case of ascending colon carcinoma. We are planning to do a laparoscopic right hemicolectomy with complete mesocolic excision and D3 lymphadenectomy. So the patient is in Trendelenburg position with leg split, and the standard ports have been placed. So the technique we follow here is craniocaudal approach by dissecting the root of mesentery and ascending mesocolon away from the underlying Toll's fascia. So here I am using that new generation Thunderbeat generator with the obvious advantages that has been told by previous speakers. The small bowel is all displaced superiorly and towards the left upper quadrant, and that exposes us to the posterior side of the root of mesentery. So the peritoneum is inside, and then we are in the avascular plane. So here one can appreciate the ureter crossing the iliac vessels. So the ureter is seen very nicely here. We have to stay into the avascular plane that lies above the ureter. As we go more laterally, we will encounter the gonadal vessels also. So the key here is to stay in the plane so that hardly any blood loss occurs. As you can see, the Thunderbeat instrument is very comfortable to dissect. And it's very handy also. It has both ultrasonic as well as bipolar energy outputs. And the planes are more augmented because of the 4K monitor here. So this craniocaudal approach initially lifts all the transverse ascending mesocolon from the retroperitoneal plane and makes easy entry while doing medial to lateral dissection. So once adequate space is made, the left hand is placed below the transverse mesocolon to further the dissection. As we progress more cranially, we will encounter the duodenum into the retroperitoneum, D2, D3 part. Once we make adequate progress, we shift the gauze piece that was placed before to retract the small bowel laterally behind the ascending mesocolon so as to decrease the lateral injury to the mesocolon and keep the field clean. So in short time, we'll see the duodenum. IVC. हाँ IVC लग रहा है.
Shreyesh, you continue doing the
Yeah.
dissection. We'll just go on to the other theater and again come back to you, Shreyesh.
Okay, sir.
Bye.
Moving on to the next place. Moving on to the next case, this is a 73 years male patient. He's a diabetic and hypertensive with cardiac history. He's presented with history of 1 year history of pain abdomen and bleeding per rectum since 1 year, with associated significant loss of weight and loss of appetite. So he was evaluated with colonoscopy that is showing the ulcerative growth in the ascending colon. Biopsy was well differentiated adenocarcinoma and HB was 9.2 and CE was 9.0. And he was evaluated with CT that is showing the only that lesion confined to the ascending colon. There is no evidence of distant metastasis. So this patient is also planned for the laparoscopic right hemicolectomy. Over to the doctor Mahesh Shetty, sir.
Mahesh, you're online, Mahesh.
This is a case of carcinoma right colon. I'll just pan out and show you. This is the cecum with the tumor here. It's quite a bulky tumor. Appendix here, just to get the orientation. And this is the terminal ileum. Rest of the abdomen looks clean and neat. And for want of time, I have dissected the ileocolic trunk here, isolating the vein and the artery separate. I think Dr. Shreyesh has shown you the inferior approach of during laparoscopic right hemicolectomy. We have two more approaches, the lateral to medial and then medial to lateral. Since this is a bulky tumor, I am not opting for the inferior approach. I am opting for a medial to lateral approach. Other than that, the technique would remain the same. Once we ligate the artery and the vein, we would be entering the Taltz fascia and then just sticking to the Taltz fascia to dissect the rest of the colon. This is the vein. I have isolated the vein now. And that's the artery. Patient is a bit obese, so there is a bit of fat on the mesentery with a few lymph nodes along this tract. can I get a clip? What I'll do is I'll divide the vein first, and I'll get a little more space to dissect the artery. Again, I'm using the instrument by Olympus called Thunderbeat. The advantage is we can safely take bigger vessels here. Can I get a clip first? I'll clip it for the sake of safety, and then I'll divide on the specimen side. Reduce it. Again, as demonstrated, there are two modes here. There is a bipolar mode where you can coagulate and then use the combination of bipolar and ultrasonic energy to coagulate and divide. I'm using the sealing mode here first, and then use the next seal and cut mode. So you can see that it very well coagulates a big vein like ileocholic vein. Okay. So you should be prepared for this problem. One more clip. Can I have one more clip? Metal clip, like a clip.
Mahesh, okay, you've secured this vessel, get the thing dissected out by the time you're able to get the thing.
Yes, sir.
We'll just go back to the other theater and come back to you again, okay?
Okay, sir.
Okay, you should switch it over to Dr. Sanjeev Patil, and then we'll come back to you again.
We can do it even at the end.
Yeah, Sanjeev, you're online, Sanjeev.
Yeah, the dissection is almost complete. So we'll transact the distal end of the at the rectosigmoid junction. 12 mm. वहाँ छोड़ दो, नीचे आ जाओ. Come, leave the specimen. This at the rectosigmoid junction, we have bared the mesentery. We have gone into the TME plane here, and we'll transact the sigmoid at the rectosigmoid junction now using a powered echelon stapler. Clean camera, clean. 12 mm port తీసుకోమా fast. So I am taking out my right hand working port 10 mm and converting it into a 12 mm port through which I will be passing the gun. Non-tooth left hand. थोड़ा पीछे पकड़ के ऊपर उठा. Lift it up. Battery system, battery. So this is a powered echelon 60 gun. As you all know, the advantages are uniform pressure and the staple line is more secure compared to the manual gun. So nowadays we have started using routinely this powered echelon. Come back. Hold my left hand. Take my left hand. 1 second now. reticulate it. Wait. Left hand. Come in, camera, come in a little. Yeah, come in. I'll leave the specimen. Leave. So I'll be transecting the sigmoid here. So always better to wait for 15 seconds for the edema to displace so that the staple line is more secure. You can focus on this one. So you can see the powered gun here. So there is a lock here which is red. You have to release the lock and then press the firing button and hold it till the firing is complete. Once you release it, automatically the stapling will be complete. One second. Come in. Give me the scissors. Come in. Okay. So I'll be making a small open incision in the left iliac fossa to get out the specimen and insert the anvil. And in another 5-10 minutes I'll be ready for the anastomosis below using a circular again a powered gun.
So Sanjeev, okay.
So the sigmoid is completely mobilized. A bit of it I'll be mobilizing to relieve any tension. Harmonic sister. Come in. So that because we are going very lower down, the whole of the sigmoid is removed. So to decrease the anastomotic tension, I am mobilizing the descending colon a bit, lateral mobilization, so that easily without any tension the anastomosis can be done.
So you can see the difference of using this new generation energy source from Olympus, the Thunderbeat, which is got the combination energy, which is showing very effective sealing, and you can see there's hardly any blood loss during this entire process of mobilization and securing these vessels. Sanjay, you continue to do this mobilization and we'll come back to you again once you're ready. We'll just go to Dr. Shreyesh and come back to you.
Hello?
Shreyesh, yes, you're on, Shreyesh.
Yeah. So we have almost reached our end point of craniocaudal dissection. So you can see all the retroperitoneum is almost lifted up except the lateral border of the duodenum. Here we can see the uncinate process of the pancreas, and the mesocolon is lifted from the pancreatic capsule. So in thin patients, sometimes we can see the posterior border of SMV also through this. Here we can see some veins draining into the SMV, but the SMV will be little bit above. So the last part of this craniocaudal dissection will be to separate the second part of duodenum from mesocolon. So that's what we will be doing now. So one can see the IVC here behind the duodenum. That is the gonadal vein, and below is the ureter. Okay. So the pancreatic head is getting pushed away from the mesocolon. This also will be a avascular area only. With the seal function of the Thunderbeat, the bleeding can be controlled very effectively. So I think we have reached our end of craniocaudal dissection. I will keep this gauze piece here for better identification. And now the patient will be placed in reverse Trendelenburg position. You can already see the gauze piece that is been placed there. So that will guide our entry into the retroperitoneum when we are doing medial to lateral dissection. Head up, please. So the key here is to retract the transverse colon up to make the mesenteric axis very straight. All the bowel will be displaced into the left lower quadrant to make the field clear. We can easily see, pan out a little bit. This is the IC junction. So the vessel coming towards IC junction is the ileocolic vessel, and this is the mesenteric axis, that is the terminal part of the superior mesenteric vein. So this V is very important in deciding the entry into the retroperitoneum. Underbit. So we will be doing D3 dissection and complete mesocolic excision. So we'll start approximately 3 cm below the V and incise the peritoneum all the way up to the base of transverse mesocolon. This can easily be done with a monopolar hook, or in this case Thunderbeat is also very useful for this. Once the mesentery is divided, the pneumoperitoneum helps in creating correct plane. One has to be very careful here because underlying superior mesenteric vein is fragile structure, and the bleeding at this point might cause a lot of trouble and maybe conversion to open also. So we can see some bluish structure below, that is the terminal part of superior mesenteric vein. I will just dissect somewhat with the instrument without energy so as to prevent any thermal injury. So that is the terminal part of superior mesenteric vein seen, and the anterior part of it is almost avascular. There will not be any anterior branches to that. So the ascending mesocolon is retracted laterally. This gives lot of leverage. You can see there are some lymph nodes here. What I am holding is lymph node. So if you do a standard right hemicolectomy, you train to divide the vessels here, this part, and all these lymph nodes will be missed. So it has been shown in the literature that D3 lymphadenectomy increases overall survival by around 10%. Another advantage I have felt in the D3 lymphadenectomy is we dissect along the vessels and stay in avascular planes. So the blood loss is also minimal and post-op recovery is faster. You can see how nicely that superior mesenteric vein is getting exposed, and all the tissue on the right side of the superior mesenteric vein will be taken with the specimen. That will be our limit of lymphadenectomy. So the dissection guide is the superior mesenteric vein. Stick along the direction and you can do a very efficient D3 lymphadenectomy for right colon. Maryland. So that is the gauze piece that is seen, that is sitting onto the third part of duodenum and uncinate process, if you remember from the previous part of the dissection. Thunderbeat. Now you can see that the axis of ileocholic vessel is leading up to this point. Somewhere here on the lateral side or right side of the SMV, we will find a superior mesenteric vein. We are not in a hurry to reach the superior mesenteric vein. First of all, we'll dissect the peritoneum and open up the dissection line, like an open book approach. But this will give adequate exposure to the blood vessel, and there will not be any hassle in tackling the bleeding. So, good overview of preoperative CT is very important to see whether the ileocholic artery is coming anterior to the superior mesenteric vein or going posterior to the superior mesenteric vein. Here it seems going posterior to the superior mesenteric vein, and that has been confirmed by preoperative CT scan. So up to here, I don't expect to encounter any arterial structure. So having exposed this much superior mesenteric vein, I will stop and I will try to enter the retroperitoneum plane that has been created by the craniocaudal caudocranial dissection. That is the gauze piece. This is the axis of superior ileocholic artery, and here you can see the arching vessel, colic branch, ileal branch of ileocholic vessels. These are the ileal branches. So we have to come here over the terminal ileum. So here again we will incise the peritoneum first, so as to create a nice plane with the pneumo. One can see it is very easy to enter into the retroperitoneal space, the Toll's fascia, and the chances of injury to retroperitoneal structures are very minimal if you have done the dissection prior. So I prefer to incise the ileal mesentery beforehand only and stop little bit short of the ileum. This enables me to give to have a very wide exposure to the retroperitoneum. So here it is expected to have ileal branches, so I am using the seal current. The Thunderbeat is very effective for a hemostasis, especially for mesenteric vessels. Camera in. Yes. So this we have reached almost up to the ileum. So I will stop here. Clean the camera once. Now we will concentrate onto the ileocolic vessel. Looks like a small lymphatic, so I will prefer to clip it. 300 clip. And here you can see the terminal part of supramesenteric artery also behind the vein. Headline. $300. A bit.
Okay, Shreyesh, you just continue doing the dissection.
Okay.
You continue doing the dissection. We'll just go to Dr. Mahesh and then come back to you again.
Okay. Thank you.
Okay.
Hello, AIG teams. Can you hear me? This is Genta from the Olympus.
Yes, Mr. Genta.
Yes. So we have received some of the query from the participant. Already we have sent you to the your chat box. So please check it, that one, and then please answer to the participant. Yeah.
Mahesh, can we just switch out to OT5, please? Yeah, Mahesh, you're online, Mahesh.
Yes, sir.
Just show the
Yeah, welcome back. What we had was a little bleed from the specimen side, which we have controlled effectively. And then I have also divided the artery. This is the artery, and then this is the vein. And as I suction, I have continued dissecting in the Toll's fascia. Once we divide the artery and the vein and the whole trunk, ileocolic trunk, and lift it up like this. Sorry, this is a bit woozy because it's a bulky disease here. We can see the duodenum, and then anterior to the duodenum, that's the Toll's fascia. I have stayed into the Toll's fascia, dividing it with combination of blunt and sharp, and then I have kept a gauze piece here. Now we can see that this is the duodenum, C loop of duodenum, and that's the head of pancreas. So what I am doing right now is dividing the transverse mesocolon to the right of middle colic vessels, and the idea is I have kept a gauze piece here, and then once I am done with the division of gastrocolic omentum, and then when I start coming to the hepatic flexure, I should be able to see the gauze piece in this region. That would be my dissection, initial dissection. After that, the last dissection would be towards the tumor, because this is bulky. I don't want to do it early in the course. This is a bit obese patient, so there is a bit of fat in the mesentery.
Okay, Mahesh, I should continue the dissection. We'll just go back to Dr. Shresh and then come back to you again.
Yes, sir, sure.
Shresh, you're online. Shresh.
Yeah, so we have isolated the ileocolic vein here. So we'll take the vein first. Vein, 5 mm hemlock. Veins are fragile, and with undue tension, it might just get torn. So better to clip the veins first and then artery. So this is the ileocolic vein that I am clipping. Patient side I will clip. Specimen side I will use the Thunderbeat 300 clip. One can very nicely see the pulsations of ileocolic artery behind the vein. Thunderbeat. So once vein is clipped, it can be pushed away, and you can see the underlying artery there. All this tissue will be taken by Thunderbeat. And then we'll encircle the vein artery before clipping. All the facial structures around the artery are dissected out. One can see the posterior wall of the artery also. It is very nice to have a 30-degree camera and an experienced surgeon as an assistant. I have Dr. Jankiram here with me. So it makes the life very comfortable. Maryland. So the artery is defined. So we'll just encircle it and then clip. That is the ileocolic artery. 5 mm. More 5 mm. So as you can see, sticking to the plane very close to vessels, makes hardly any blood loss. So this is the beauty of D3 dissection. So the blood loss is very less.
Yeah, Shreya, that's a very good this thing actually. There is a question from one of the participants. He's asking, what is the landmark to isolate and find the SMV in this case?
So like I told, once you retract the ileocolic IC junction towards the lateral most part and lift the transverse mesocolon straight away up towards the head side, head end, then the ileocolic vessels will be seen as going towards right iliac fossa, and the superior mesenteric vein will be straight up. It will form a, I will show. So here the transverse mesocolon is lifted up and retracted toward the head side. So the straight line, a straight ridge that is formed is because of the superior mesenteric vessels. Vein will be anterior and artery will be posterior. So as the vein comes down towards the caudal side, the artery will slowly turn onto the right side of the vein. So this is the normal usual anatomy.
Thank you, Shreya. Actually, we'll just go back to Dr. Sanjeev and then we'll come back to you again. Okay.
Okay.
Okay, Sanjeev, you're online, Sanjeev.
एक मिनट ना बस तेरी पुश मत करिए दादा अम्मा ना
Sanjeev, you're live.
Instrument come back. Yeah, we have inserted the anvil of the circular step. Go back a little, थोड़ा पीछे उठाइए गन थोड़ा. We have inserted the, come back, anvil of the circular stapler here. Back, camera back, पूरा दिखाओ. Usually we do a end of the proximal end to the side of the distal end, so that one staple is saved as well as we gain some length by doing a end of the proximal end. Come back, back camera. Thoda gun back. Yeah, you can perforate now. एक minute. Yeah. थोड़ा गन टेंशन है, थोड़ा बैक. बस.
Okay.
Yeah. Come in.
Counter pressure.
ठहरे. ये रिलीज हो जाएगा. आ जाइए हो जाए. Yeah. Yes. Gentle. गन ज़्यादा पुश नहीं कर. थोड़ा ऊपर उठाइए गन. नहीं वैसा नहीं, उल्टा. Yeah. Yes. Orange आ जाएगा. I'll show it. So the gun that we are using is again a powered circular stapler that's also come newly into the market. Same advantages, it is uniform pressure is applied at the anastomotic site, so the chances of anastomotic bleed and leak are significantly lower with the powered circular. In second, give me a Maryland system. थोड़ा लूज टाइट हो रहा है. Marylands, come in camera, come in. Yeah, enough. Come back, show me this. Show me the lie of the intestine. Okay. Come close, camera.
Yeah.
One second. Hold this, sister, hold this. ठीक है, आप ये कर सकते हैं. You can. Come in camera. Okay. Come pressure अंदर आ. Tighten कर सकते. You can tighten. So we'll now tighten the stapler now. Show me any tension on the proximal end. So you can see here there is no tension because the sigmoid is mobilized well laterally. Show the staple line. Yeah. So the staple line. Yeah, I said the camera. Okay, fine. On है क्या वो बोलिए फिर forward you can explain.
This has to be in the green zone. Can you focus here?
Focus.
It's gone beyond the green, so it's adequately tight. So this powered gun has a adjusting technology. It's called gripping staple technology, whereby the clips will put pressure adequately wherever it is required. And the clips are going to form, they are going to get oriented in 3D. So we are basically waiting for about 15 to 20 seconds for that pressure or the water which is there to get compressed. And then we are going to use this powered gun, which is going to give us uniform application of the pressure and the 3D staples.
ICG loaded ना? Okay.
Wait. ICG के लिए जरूरत है ना?
नहीं. बात नहीं. After anastomosis.
There is a lock which we have to unlock, and then just a little push of the button. You need not keep it pressed, just a one push, the anastomosis get completed and you get a green tick. This green tick is suggestive that everything has gone well with the stapling and the anastomosis. We'll wait for another 15 seconds and then we are going to get the gun out. So without any jerky compression, pressure more on any one of the walls, this is a uniform compression. The staples will have 3D alignment. The vascularity of the cut ends remains more. So the chances of leak of anastomosis come down. Another thing is when we are going to open this stapler, otherwise we used to put it into the anti-clockwise 2 turns, 3 turns. Here we need 2 full turns. After that only it is going to be easy to get the stapler out. So we'll start rotating. And now with the swinging movement from one thigh to another, we can start getting the, you can see the stapler is coming out. And that's the anastomotic line. 3D alignment of the staplers with GST technology.
Yeah, you can just take it okay out. Okay, out. Okay. This is the suction humor.
So we'll just confirm the donuts.
Come back. Show me this tension. So the anastomosis is complete now and you can see there is no significant tension. There is no tension at all on the anastomosis. The sigmoid is freely falling there.
Forceps.
I see. Sir, आप आने के बाद इंजेक्ट करेंगे सर. I see. So the other thing that we want to demonstrate, the surgery is done now, but we want to demonstrate the utility of indocyanine green, that is ICG in colorectal surgery. So one of the indications is to look for the vascularity of the anastomotic ends. So that's what we are trying to take the ICG scope. We are trying to show here. We are now changing the scope over to the IR scope, that is a infrared scope which Yeah. Okay, fine.
So I'll just show the completeness of these donuts. It's very important to have a look at these donuts, which side they are deficient, if at all. So this is perfectly uniform thick donuts on either side, both upper and lower end, which suggests that the anastomosis has been done quite effectively with the stapler, and so it should be a good anastomosis. Over to Sanjeev.
Yeah, the utility of ICG we are trying to demonstrate now. This is the anastomosis which is complete now. We are giving indocyanine green intravenously.
Yeah.
And within few seconds, approximately around 30 to 50 seconds, you will be able to see the bright green fluorescence of the indocyanine green at the anastomotic end change. So we are now switching over to the ICG mode. So the indocyanine green dye has already appeared at both ends of the anastomotic site. Now you can see here both the ends are fluorescing very well with the green light, indicating that both the ends of the anastomosis are very well vascular. The other thing that we are trying to show is we are trying to do a on-table colonoscopy to see for the anastomotic end. That is one of the ways of identifying the integrity of the anastomosis as well as whether there is any bleed on the anastomotic site. We can give gentle this on-table colonoscopy has to be done by a very experienced endoscopist, because the anastomosis will be under tension, so any high pressure insufflation may cause disruption of the anastomosis.
So actually, yeah, you can see this. Actually, we have now an objective evidence to show that the anastomotic site is very vascular and the chance of leaks are very less with this indigo cyanine green. Now, there is a lot of data to show that intraoperative endoscopy during the procedures is very helpful to check for any bleeds at the anastomotic site and also for any leaks that can be tackled on table. Now we can beautifully see that this is the anastomotic site here. Can you see this? This is the anastomotic site here. There's hardly any bleed at the anastomotic site. It's completely secure. There is no discontinuity in the staple line anywhere here. So now these two technologies, actually what we are using, one indigo cyanine green to check for to objectively show that both the ends of the anastomosis are absolutely well vascularized, and other intraoperative endoscopy procedures like this to check for any bleed, because any of these bleeds that we see right now here can be very effectively secured by putting a clip or something of that sort, or if there is any discontinuity in the staple line, we can always secure it laparoscopically. So this is the biggest advantage, and there is a lot of data to show that these intraoperative procedures decrease the postoperative morbidity and mortality in these patients. I hope this can be, just show that one.
Switch over to the regular one. IR, change the mode. So now we are very sure that the anastomosis is secure and there is no bleeding at the anastomotic site. So in such a procedure, we usually do not do a stoma. We'll just put a drain in the pelvis and then come out. So the procedure will end now. And the other thing is IR, the main advantage is it is excreted fast, and you can again multiple times you can inject ICG and then see for various reasons, either it could be a lymph nodal dissection or anastomotic integrity. So repeatedly you can use ICG in such procedures. So we'll put a drain in the pelvis and then we'll complete the procedure now. Thank you. 28 drain. 28 drain. So we'll be going to the next theater now. Right hemicolectomy. Come close. Come close. Show. Sister. 28 drain.
Okay. So we are coming to the last part of complete mesocolic excision and D3 dissection. as you can see, we have made significant progress till the neck of the pancreas. So here, this is the superior mesenteric vein. This is the artery that is originating from superior mesenteric artery. Initially, it looked like a right colic artery, but it is actually a middle colic artery, which is giving right colic branch. So this branch you can see here. Then it is going up and then dividing into the left branch of middle colic and right branch of middle colic. So since this is a ascending colon malignancy, we will be doing, we will be ligating the right branch of middle colic artery only. So this is the right branch. So first we will ligate the right colic artery, Maryland. With gentle dissection, first we have to encircle the vessel before putting a clip. So this avoids unnecessary bleeding. Fascia around the vessel sometimes might be very tough, and one might get a feeling that we are entering into the wrong plane, but it's not like that. So this is the right colic artery that will clip now, 5 mm hemlock. Very important to see the other end of the clip also. Sometimes we might capture some important structure and then regret it. So a nice encirclement of vessel and then clipping is advisable. Thunderbeat. It was demonstrated in the anterior resection that Thunderbeat is very efficient in coagulating the small branches. And we are not doing that because the purpose is served, and still we are following the conventional way of clipping the branches wherever they come. As we move more cranially, we will encounter the gastrocolic trunk. There will be usually a lot of variability in the formation of gastrocolic trunk, and one has to be aware about the variations that might be present. But usually the veins that one has to ligate are right colic vein, accessory right colic vein, and middle colic vein sometimes. So these are all, there is a lymphadenopathy here. I am trying to clear the lymph nodes. Anyone? So first of all, now we will take the right branch of middle colic. That will open us the entry to the lesser pack. One more. Thunderbeat. Very good. As we ligate the right branch of middle colic, we enter the lesser sac. At the start of the surgery, we had already dissected the entered the lesser sac and dissected the mesocolon away from inferior border of pancreas. So that gauze piece you can see that is kept in the lesser sac. So we just lift this nodes away, expose the gastrocolic trunk, and then approach the gastrocolic trunk from the lesser sac, because that is easier than approaching it from inferior side. All the lymph nodes are swept away from the head of the pancreas to achieve a complete D3 lymphadenectomy. As we go towards the neck of the pancreas, we will see gastrocolic trunk, some bluish structure you can see lying onto the head of the pancreas, and that most probably is the gastrocolic trunk. Bowel gasper. So now we'll change our working instrument. Non-tooth, underbeat. So this gives a better angle for dissection. That's out. In such critical areas, one has to be very careful, and any kind of haste should be avoided. So now one can see that multiple veins are coming here in this area. So what are those veins will define from the lesser sac side. So one of it will be gastroepiploic vein, one of it will be right colic vein, that will see on from the superior aspect. So first these lymph nodes will dissect up. Oh, that is the gastrocolic trunk that can be seen going into the SMV. So turn the camera here. Here one can see here that gastrocolic trunk is entering into the superior mesenteric vein. And we are right onto it. Please come back. So we'll stop here and go to the exercise side.
Okay, Shreyesh, you continue doing the dissection. We'll just go back to Dr. Ranjit for a presentation on the new Thunderbeat, actually, the technical specifications, how it is superior to the conventionally available energy source. So Dr. Ranjit, the consultant at AIG Hospitals, he'll be giving us the details of how this new Thunderbeat that has come from Olympus is different from the conventional Thunderbeat, and what is the advantages of this. Over to Dr. Ranjit.
Thank you, sir. Good evening, everybody. So I will show you a presentation on the new energy platform system of Thunderbeat from the Olympus. So it's recently been, the old system has been revamped into a new one where they have made certain modifications to suit the everyday need of the surgeons. So as you all know, Thunderbeat is the world's first and only advanced energy system that delivers two well-established forms of energy to the tissue simultaneously. That is ultrasonic energy for superior dissection and fast cutting, as well as advanced bipolar energy for secure hemostasis and sealing of vessels up to 7 mm in diameter. So this is the slide which shows you what technology is in Thunderbeat. There is a hybrid energy of ultrasonic and bipolar energy, both simultaneously. And you can see that in the instrument there are two buttons, seal and cut, and there is a seal button. The seal provides the bipolar energy, seal and cut provides the hybrid energy simultaneously. And the advantage being, I will come in the next few slides. So the video there shows that the ultrasonic technology applies the frictional heat, which provides the fast cutting capability, and the bipolar energy provides the concentrated heat or the Joule heat, which provides the high sealing performance. And if the video is, there's one more slide which is on the other side. I would put it in the next video. Here you can see that how exactly the Thunderbeat works. Yeah, that there you see in the center there is the ultrasonic energy. On either sides are the bipolar energy which works. So it provides a good seal, and then the ultrasonic is used to cut the tissue. And this video shows you the fast cutting capability of the Thunderbeat system. So you can see that there's hardly any blood loss, and it's quite rapid as well compared to other ultrasonic device. That is, the hemostasis is very secure and reliable. You can rely on the hemostasis that is provided by the Thunderbeat technology, and also saves a lot of time. You don't have to go back to the tissue because it's probably bled back, there's a back bleeding. And also the another advantage is there is only bipolar mode. You can also provide a spot coagulation like seen in the video here. See, as when you're dissecting, you find there is a spot that is bleeding, you can go and coagulate it. That's the advantage. You can stop the bleeding by using this bipolar mode. And this is in a nutshell puts the concept of Thunderbeat, what exactly it does. It does, see there is the diagram there which shows that there's an ultrasonic and there's an advanced bipolar. When these two act, it provides all these five, and also the Thunderbeat has got this grasping capacity, which helps in secure grasping also, and also this fast opening capacity, which helps in precise dissection. So this was a general introduction on Thunderbeat. So next, I'll be coming to the specificity of the new model, the Thunderbeat, the new generator which they have. You can see from the slide here, the standard, the tissue, this thing, sealing system has got, this new system has got 34% efficacy compared to that old system. So the algorithm for seal mode has led to a shortened time with the help of this intelligence control. And also you can see from this slide here, normally conventional generator, there's a constant application of power. So initially in the phase 1, you see there's a constant power, and then the phase 2, when the seal is completed, that is when the power stops. So there is a more need for power in the conventional generator, but whereas in this new generator, it's a variable power applied. When there is a maximum need for power, that is the sealing, that is when the phase 1 there is a maximum power. But once when you are nearing the seal, that is when the phase 2. Once the seal is done, there's automatic shutdown of the power. So this variable power control helps to optimize the power depending on the tissue resistance, and also makes it very faster sealing. So these are the certain modifications that you are seeing in the newer generator. And also there are these unique tip designs, which I was telling earlier. There is a wiper jaw mechanism, so that the conventional jaw design is such that it's like a nutcracker. It just cracks the tissue there. But in the wiper jaw, it opposes onto the shape of the tissue. So there is more application of the energy. So there is uniform tissue compression also. So that is the reason there is a uniform power application. So you see that there is no loss of sealing in one part. So it's uniform seal. So that's the advantage of this tip design as well. And then there are other advantages, like there is less of mist generation as seen in this video. You could see that there is that is a Thunderbeat tip design. What you saw earlier was other companies, but in this you can see there is a lesser of mist generation during surgery. That also is helpful. Otherwise you need to keep interrupting your surgery because of this mist generation. You may have to open those ports, let the gas out, or maybe use suction. So it might interrupt your surgery, but this being there, it helps you to proceed your surgery fast. And this is the technology behind the new generator. What you see is that it's a very simple and easy setup. During the surgery, it must have been shown to you. The generator is a very compact one, as seen in the picture here. There's only one socket which provides both for sonic beat and for Thunderbeat. And also you see on the left hand side, the picture, there is only one optimal seal mode. That means anybody doing the surgery, there is no difference in the seal. And if suppose somebody had changed, imagine it's an old generator, somebody had kept the seal on the higher level, and then the next surgery, if unknowingly you may have used the seal. But this only one optimal seal mode ensures that you are providing a very good seal, whoever is doing the surgery. So there is no, one has to not worry about hemostasis. And also there is a doctor optimum controls also. That means if suppose some surgeon prefers to operate in certain settings, he can use it again and again for his surgeries. So it is easy for the surgeons as well, and easy for the technicians who handle this in the surgery, in the operation theater. It is one socket, so and it's compact, consumes less space, so it's easy to handle. And like shown in this picture, it's the smallest size ultrasonic bipolar generator. You can see the comparison. I'll show you in the next photo that we have a real life, the life size picture of a generator. Saves space a lot. See, this is the one which is there in the operation room itself. You can see on the left hand side is the new generator. On the right hand side, the lower one is the old generator, and on the top is this thing. Electrical surgical generator. And there are certain additional benefits like auto smoke evacuation functions which are provided by the Olympus Thunderbeat system. So you can see that in the picture there, that as and when the smoke is generated, it is being sucked out by the system provided by in the generator itself. And this feature of intelligent tissue monitoring ensures that there is a reduction in the unintentional temperature increase. So what happens is, suppose when the power is being generated, when the maximum seal pressure has been obtained, you want you are planning to the tissue is being divided. You don't want the power to overshoot. So this intelligent tissue monitoring ensures that power doesn't overshoot. So whenever the seal has approached that is when the power automatically reduces, then the output from the generator stops. So that's the advantage of this intelligent tissue monitoring, which helps in lowering of the temperature so that there is no thermal spread. So that's the advantage. So this optimal temperature control, as I just put it in the slide. So it provides, precise, with the help of this intelligent tissue monitoring, precise dissections close to vital structure is possible because of minimum thermal spread. And is the first and the only safety assist system for ultrasound-driven technologies. And also, it has been shown in a study that it leads to decrease in the residual probe temperature by significant, almost more than 20 degrees Celsius, and it's so very safe. So that is the advantage of Thunderbeat, that is all-in-one versatility. So there is a automatic tissue grasping, there is a Viper jaw technology, there is a good dissection which is possible, and a fast and reliable hemostasis even under challenging condition, and reduce misgeneration for improved visibility due to the proprietary technical design. So this is one of the videos where we show that there is this Thunderbeat being used. The smoke, as an when it is being formed, it is automatically evacuated, and with the help of the Thunderbeat, you can see that the dissection also, one can do very precise dissection. You can use the tip itself to open and create spaces, and proceed with the dissection as and when you are opening the planes. So this video actually demonstrates that. And if you are in a very good plane, you can see that there is hardly any blood loss, because any small bleeders can be tackled with the seal provided by the system. And also the blade, the unique tip design helps you to dissect in a very efficient way. It acts like a curved dissector. So this was a presentation on the newer generation generator technology of Thunderbeat system. So I will hand over the session to Mr. Jenta Ushiru, because he's a technical expert on this. He will be able to tell you further if you have any clarifications on this. Thank you.
Thank you very much, Dr. Ranjip Rao. Based on your experience, it's really good presentations. Yeah. From my side, we would like to highlight to the 3 points of our new Thunderbeat generator. Already all points covered by the Dr. Ranjip Rao. One thing is new Thunderbeat is a 7 best reliable sealing and fast tissue cutting capability. And second point is compared to the legacy generator, it's maximum 34% faster for sealing speed. So that's why not only like a very good sealing in the performance, this time new generator sealing speed is really improved. And the last point is such kind of the improvement of our the performance. But this is the smallest ultrasonic bipolar generator in the world. Yeah, compared to the previous legacy generator, almost 3.8 times smaller than that one. Yeah. So if you interested in like our generator, yeah, please contact to us. Thank you very much. Thank you. Yeah.
We'll go on to the right hemicolectomy OT to Dr. Mahesh. Mahesh, on.
The mesentery. This is the artery trunk, artery and vein trunk, ileocolic trunk, and then after that I have entered into the Gall's fascia. So I have done the dissection all around. Here is the hepatic flexure colon. That was a gauze piece which I had kept earlier during dissection. Now you can see that the liver is visible from here. I have also divided the transverse mesocolon right of the middle colic vessels. Only the bowel needs to be resected. Here you can see the duodenum and the head of pancreas, and all the lymph nodes have been included here. Coming down onto the small bowel, the small bowel mesentery has also been divided. That's the marginal artery. Since the patient is on antiplatelet drugs, I have clipped it. Otherwise, you could happily take it with Thunderbeat. Coming down, we have mobilized the colon cecum appendix from the retroperitoneal area down up. Okay. And then we are just left with the peritoneal tissue hanging out. So I'll just take the, because there is a little bit of inflammation around, I would like to take it with a little bit of peritoneum margin. So once the dissection is done, because this is a dilated tumor obstructing, I would like to do a extracorporeal anastomosis.
So Mahesh, that is an excellent dissection.
Yeah.
We've seen medial to lateral, and now the lateral border is being released. We'll move on to the next theater, to Dr. Shreyash, who is also completing his right hemicolectomy.
Yeah.
Over to 47.
बाहर निकलने के पहले थोड़ा सा वेट करो. हाँ. नहीं ये इधर
Shreyash on.
पूरा लेफ्ट साइड में दिखाना है ना.
Dr. Shreyash, can you listen? Shreyash, your mic is on.
Okay, so we are almost finished the dissection. Only lateral mobilization is remaining. So you can see this wall graph. Right up తీసేయండి కొంచెం. You can see this completed D3 lymphadenectomy. So this should be the field that should be seen after every D3 lymphadenectomy. That makes the surgery very standardized. So that is the right branch of middle colic. This is right colic. These are ileocolic vessels. This is the complete bared right border of SMV and SMA, duodenum, and head of the pancreas is seen. If you see from superior aspect, these are the right gastrocolic vein, which is turning here and forming the gastrocolic trunk, going into the SMV. These are the colic veins that are draining into the gastroepiploic. These are the colic veins that have been clipped, draining into the gastroepiploic vein, forming gastrocolic trunk. So only the lateral dissection is remaining. Once all is done, it is very easy to do lateral dissection. So one has to be aware of many congenital adhesions that are present sometimes in this area. So this is the actual told line. Like it goes in any surgery, constant traction and counter traction are the key to open up planes. And in laparoscopy, the pneumoperitoneum also helps. So those are the gauze pieces that have been kept above hepatic flexure, which is already mobilized. And we have reached the end of our dissection. Photograph for you. So always remember to remove all the gauze pieces that have been kept at the beginning of dissection. Oh. Can flip the colon and see the completed dissection. So here we will be doing a extracorporeal anastomosis through a small incision. So meanwhile the abdomen is prepared for laparotomy. We want to show a small innovation kind of thing that we have made for training purposes here.
Yeah, thank you, Shreyesh. Actually, that has been an incredible dissection. See, all this looks very simple actually when we start doing all these procedures actually, but there is a lot of effort that goes into get practice on this. And one of the questions that was posed by the people who registered for the course was that they didn't have adequate access to training and all these facilities. But this holds good for any of the center, even in tertiary referral care center. It is not that everybody is exposed to high volumes to do these procedures, but ultimately it depends on the passion of the surgeon as to how much of experience, how much of time and effort that he wants to put in to learn these new skills of laparoscopy. So as we all know that actually because of limited resources, limited cases that we have, there has been a lot of stress from various societies and also institutions for training models which can be used to simulate the procedures and also gain experience for these procedures, especially the advanced suturing techniques, advanced dissection techniques actually. The best thing would be to do on these live animals, but actually there is again a lot of limitations to availability of this and it's available in only select centers and very few people have access to this. So to overcome that, actually, we have seen a lot of these pelvic trainers that have come being used in clinical practice. Actually, some of the surgeons are already using these pelvic trainers for the training themselves. I am very glad that actually Dr. Shreyesh, who's the consultant here, you have seen his dissection actually. I mean, it is not that simple that actually it's not that he's got about 20 years of practice or something of that sort. Just into practice, confidence that he has in dissection. This entire thing is basically because the amount of time that is spent behind the scenes practicing all these procedures on these pelvic trainers. And for him, he has innovated a pelvic trainer for himself actually, which we thought it's very useful actually. So it's a very simple thing which he is innovated, and it is a smart innovation actually. That's what I call actually. I think I'll ask Shreyesh to give you the details of the thing, how it is useful, and how simple it is to assemble the whole thing and how it can be carried. It's a portable stuff. It's a smart device, and we can record the entire stuff, and it gives us that confidence to the surgeon that he can do these procedures very confidently as and when the situation arises. Shreyesh, it's all over yours, Shreyesh.
Okay. So, like sir said, to master any difficult technical surgery, one has to develop both cognitive skills as well as psychosomatic skills. So the cognitive skills can be developed by watching your expert videos on YouTube or any other society websites. But to develop psychosomatic skills, one has to practice. And to practice, one needs a place to practice. Patient is not a practice. That has to be kept in mind. So to practice, there are different kinds of simulators and trainers available. So ideal trainer or ideal endo trainer should be very simple, it should be portable, and it should be modular. Modular means it should be able to get adjusted to any situations and anywhere you can practice that. So this is a small contraction that I have made. This is a box that is easily available in the market, and that has been turned into an endo trainer. So this doesn't require any light because the sides are open, and daylight also can be used for practicing. A simple camera like our mobile camera can be used, and this can be practiced in even office also. while sitting in OPD or while waiting for surgery, the technical skills can be practiced. So a simple mobile camera can be connected because of the now new smart technologies. It can be connected to a smart TV by screen mirroring or through wire, and that gives a very good hand-eye, good exposure to hand-eye coordination. So here, this is one that we have developed.
So I hope you can see this. This is a very simple box. Actually, I'll just turn this and show it to you. See, this is just a box that is available. It's illuminated inside, as is rightly said. We can use daylight or this. Now this part of the thing has been modified now. Here you can see this. Now this has been modified to have, usually we should have a camera port here to do this. Now he got away with the camera by using this mobile. You can see this. We are using an ordinary mobile here, using this as a camera. And these are the ports that are here. The biggest advantage of this thing is we can practice seeing this. We can record this entire procedure, what you're practicing, so that we can get back and see what you've done. And at the same time, if you have a smart TV, you can always mirror your image onto the thing and have a bigger image to practice on. So this is the biggest advantage. You can see this, we are getting rid of, we don't have a regular camera here. He is using the regular mobile camera here to put this onto the thing actually. And then the biggest advantage that I found is actually the image quality is excellent. Two, we can record this entire procedure as you're practicing so that you can always improve upon yourself.
So like sir said, it's very portable. You can practice anywhere, in home, in OPD, in OTs, and it is very portable, so you can carry it anywhere, even on two-wheeler also. So second thing is this has hinges, so the angle can be adjusted. In many commercially available endotrainers, the adjustable angle is not there, which I found, and it was very restrictive in developing different types of skills. So if you want to train a certain task, you can adjust this box according to your requirements and train it. Second thing is there is a small one. If you see any human abdomen, because we are practicing GI surgery, so abdominal surgery is our area of interest. So any human abdomen doesn't expand beyond 10 to 15 centimeters even after insufflation, and posterior-most organ of interest, pancreas or retroperitoneum, is in fact only 10 to 15 centimeters from the abdominal wall. So you do not have a big endotrainers where the camera is far away from the operating field, and this helps in decreasing the distance between the camera as well as the operating field.
And as he rightly said, actually, see, we can adjust this height of the thing so that the angle can be adjusted. Can we just loosen this actually? See, basically it is a very, I'll show you the inside of the box also. The biggest advantage is like you can adjust the height of this depending on the depth of the thing that you want. And ultimately you can see this is an easily carryable thing actually. All you can do is just lock this entire thing and carry it wherever you want. So this actually has been a very good thing actually. I mean, a lot of our juniors seem to be practicing on this actually. Even I never knew about this actually. The juniors are practicing on this, and their skills have developed tremendously because of this backstage training that they're doing themselves before they're coming onto the live surgeries. Thank you so much again, once again. Thank Olympus. I thank our AB team at AIG Hospitals and the entire theatre staff who has been coordinating extremely well. All the faculties at the AIG Hospitals, the theatre staff who have been behind the screen working for these surgeries. And I once again thank Olympus for coordinating this entire academic event. I hope we'll come back again with...
Hello, Dr. Lau. Thank you very much. Still, actually, like Professor Jin Kim and also Dr. Kai Uehara stay here. So please, kind some of the message from Dr. Lau to such kind of the faculties.
Thank you. Thank you so much. Thank you so much, actually.
Okay, thank you very much. Yeah, thank you very much. So okay, for dear all participants, when you're leaving these sessions, you will jump to the feedback form pages. Yeah, this is very important for our, the future webinar. So please kindly fill it that one. Yeah, once you fill it, such kind of feedback form, also from our side, we will send you some of the case report. Yeah, thank you very much today. We would like to finish now. Yeah, thank you very much. Yeah.
Thank you.
Thank you very much. Thank you.
Thank you. Congratulations. Thank you.
Thank you very much. Congratulations.
Thank you.
See you.
See you. Okay.
See you. Bye.
Good.